Assalamualaikum everyone, I am Siti Ali Kamila. I and my friend would like to present our case study about nutritional management for patients with fracture of right neck or femur and poor oral intake. For the introduction, I would like to explain about the patient's personal detail. The patient's name is Mrs. F. She is a 72 years old and a Malay. She lives in Dungun, Kuala Terengganu. She is a married woman and a housewife. Currently, she stays with her son at Dungun. She is a non-active or passive smoker. Previously, she was diagnosed with Parkinson's and was a semi-independent, which she able to walk on her own slowly. There are no family history of Parkinson, hypertension, diabetes mellitus, and ischemic heart disease. Currently, she was bedridden due to the closed fracture of right neck or femur, which is at the thigh bone, and also Parkinson. She was referred to pediatrician due to the poor oral intake.
Hi everyone, I am Azliza binti Rahmat and I'll be presenting the medical diagnosis of our patient. In our case, Mrs. F is diagnosed with Parkinson's disease by the medical doctor. However, she does not have any family history with the disease. Parkinson's disease is known as the second most common neurodegenerative problems after Alzheimer's disease. It normally affects movement as it gradually develops, initiated by tremor in one hand. People with Parkinson's disease might experiencing dopaminergic neurons of substantia nigra loose, thus develops movement problems such as bradykinesia, tremors and also stiffness. Postural instability or falling might occur during the later stage of Parkinson's, and also they might have soft or unclear speech that will influence the oral intake and might cause difficulties in chewing and swallowing food, that also called dysphagia. Both younger and older generations are exposed to the chance of developing Parkinson's. However, as age increases, the risk also increases, and people aged 60 years and above has the higher risk. Men are more prone to get Parkinson's compared to women, and people with many family relatives with Parkinson's disease has higher risk to develop Parkinson's. Also, people that more exposed to toxins has higher risk to develop Parkinson's. The main causes of Parkinson's is still unknown, yet there are two factors that play a role in developing Parkinson's, which is genetic and environmental factors.
Hi, I'm Amran Hasha. We proceed with the medications taken by Mr. F. First, for levodopa, which is used to treat Parkinson's disease, has some side effects such as nausea, vomiting, hypotension, dyskinesia and confusion. Next, for heparin, which is administered via intravenous injections to prevent blood clot formations, has some side effects such as chest pain, abdominal pain, constipation and dizziness. Next, for pantoprazole, which is used to treat gastroesophageal reflux disease, has some side effects such as diarrhea, headache, nausea, joint pain, decreased urination and irregular heartbeat. Next, for paracetamol, which is used to relieve fever and mild pain, has common side effects such as drowsiness, fatigue, rashes and itching. Next, which is tramadol, is used to relieve moderate to severe pain, has some side effects such as dry mouth, constipation, sleepiness and difficulty in swallowing or breathing. Next, ascorbic acid, which is used to prevent scurvy and promote wound healing, has some side effects such as nausea, fatigue, flushing and diarrhea. Next, for salicylic, which is used to treat Parkinson's disease, has common side effects such as insomnia, dizziness and nausea.
Assalamualaikum, my name is Nur Izzah Anis. Mrs. F current medical diagnosis of first is closed fracture of right neck or femur, and second is a Parkinson. She has been referred to dietitian due to poor oral intake problem. So the first nutritional assessment is the anthropometry data. The estimation of for weight and height were used based on knee height and mid upper arm circumference measurement. Weight prediction of Mrs. F was 56.5 kg using the equation proposed by Ross Lab et al. Meanwhile, for the height, is 153.5 by using the equation proposed by Susanna and Nerd 2000. Her BMI was 23.8 kg per meter square and classified as normal. The ideal body weight for Mrs. F was 53.2 kg with BMI of 22.5 kg per meter. The ideal weight range was calculated using the normal range of BMI, which was in the range of 43.7 until 58.8 kg. Mrs. F knee height and mid-upper arm circumference were 46.5 cm and 26.9 cm respectively. For the second assessment is based on biochemical data. There are three values that reported being abnormal from the normal range. The first is urea level, which is 8.1 mmol per liter, which was higher than normal range. It can be indicated that her kidney may not be working very well, and the other value usually due to liver failure, dehydration or shock. Secondly is the red blood cell count. It recorded at 4.45 times 10 power of 3 liter, which was slightly lower than the normal range. It is due to lack of essential nutrients like iron, vitamin B6, B12 or folate, or can be indicated for anemia disease. Thirdly is the albumin level reported at 31 gram per liter, which was below the normal range. It is due to protein energy malnutrition. Third assessment is based on clinical data. Blood pressure of Mrs. F is reported higher than normal range and being classified as hypertension stage 1. The fourth assessment is based on dietary data. The estimated energy intake by Mrs. F was 623.3 kilocalorie with approximately 38.1% from the energy requirement. The estimated carbohydrate intake was 125.4 gram or only 51.2% from the carbohydrate requirement. And the estimated protein intake was 19.6 gram or only 34.7% from the protein requirement. The estimated of fat intake was 5 gram with only 10.5% from fat requirement. The estimated of fiber intake was 5.2 gram. The carbohydrate distribution from Mrs. F diet was basically with 3 exchange during breakfast, 3 exchange during lunch, and 2 exchange during afternoon tea. After the assessment, there is 3 nutritional diagnoses. The first is inadequate protein energy intake related to poor oral intake as evidenced by patient 24-hour diet recall reporting the estimated energy intake of 623.3 kilocal or only 38.1% from energy requirement of 1,634 kilocal per day and estimated protein intake of 19.6 gram or 34.7% from the protein requirement. And the second one is inadequate fluid intake related to poor oral intake as evidenced by patients 24-hour diet recall reporting the estimated fluid intake lower than the requirement of 1,695 ml per day, approximately 30 ml per kilogram body weight. And the third one is inconsistent carbohydrate intake related to nutrition-related deficit knowledge concerning appropriate timing of carbohydrate intake as evidenced by patient 24-hour diet recall reporting estimated carbohydrate distribution. Okay, this is our comparative standard. For the estimated energy requirement, we calculated using 3 equations. Then the chosen energy is 1,634 kcal per day by using Harris-Benedict equation. For the protein requirement is 56.5 gram, which based on ESPEN 2009, where only for 1 gram per kilogram of body weight is. For the macronutrient distribution, protein with 56.5 gram, carbohydrate with 245.1 gram, and fat with 47.5 gram. Then there are 3 objectives for nutritional intervention. First is to achieve sufficient energy at 1,634 kcal per day and protein intake at 1 gram per kilogram body weight. Micronutrients to meet nutritional status requirement. The principle is to encourage patients to take orally and protein sourced through hospital diet and to give additional food or oral nutritional supplement to improve the nutritional status and to serve food in small quantity but frequent timing and to encourage patients to finish all the hospital diet. The second objective is to reach the recommended fluid intake for elderly aged more than 65 years old, which at 1,695 ml per day, approximately 30 ml per kilogram body weight. The first principle is to serve water during and in between meal time to achieve 60% or direct fluid intake, approximately 1,070 ml. The second is to provide fruit and vegetable that high in fluid content to meet the recommendation of 40% of indirect fluid intake, which is 678 ml. The third objective is to educate the patient with nutrition-related knowledge concerning appropriate timing of carbohydrate intake and energy balance. We educate carbohydrate distribution and exchange throughout the day and educate on types and quantity of carbohydrate and educate on appropriate meal times, reduce. For anthropometry, we need to monitor weight in weekly basis to ensure there is no sudden weight loss and to maintain normal body weight. Second is a biochemical. We need to review back her renal profile, full blood count, and also liver function test to ensure that the biochemical values are in the normal range. And the third is a clinical. We need to assess back the blood pressure, body temperature, pulse rate, respiratory rate, and oxygen saturation to ensure that the value is also in the normal range. And next is the dietary. We need to assess the patient dietary data and to evaluate Mrs. F has incorporated dietary changes and to ensure that patient reach 60% of energy and protein requirement and take regular meals with appropriate food choices. Menu planning is done based on the estimated energy requirement of 1,634 kcal per day. We distributed low-fat meal at breakfast and supper. For simple sugar, we put it during lunch. For 2 servings of fruit, we put at lunch and dinner respectively. For leafy vegetables, we put 1 exchange at breakfast and dinner respectively. And the remaining 2, we put at lunch. For the rice, we distributed for 2 exchange at each meal times. And for the protein, 1 exchange of fish we put at dinner. Meanwhile, 1 exchange of lean meat or poultry we put at lunch. Lastly, for 5 exchange of fat, we put 2 exchange at lunch and dinner respectively, and the remaining 1 at breakfast. In the table, we can see that the difference between total carbohydrate requirement with the planning one is 3.9 gram at 101.6%. Then for the protein, the difference from the requirement is 2.5 gram at 95.6%, whereas for fat, the difference from the requirement is at 1.6 gram at 96.6%. Lastly, for the kilocalorie, the difference from the requirement is at 21 gram at 101.3%. Then this is menu planning for weekday 1 and menu planning for weekday 2 and also menu planning during weekend.
For discussion, Mrs. F current medical diagnoses are closed fracture of the right neck of femur and Parkinson's disease. Patient with PD is likely to have low bone mineral density, muscle atrophy and sarcopenia. The weakened muscle will no longer provide enough protection to the bone by absorbing mechanical impact and stress. Hence, the dietary intervention for Mrs. F will take into account to counteract the progression of this condition, to maintain calcium level of bone and preserve muscle mass. Next, these are the clinical aspects of femoral fractures. The pain is usually relieved when at rest, but reoccur or worsen when continue movement. Although Mrs. F is provided with drugs to relieve pain, integration of fall prevention steps, education regarding fracture bone care, behavioral modification and exercise classes will be beneficial for a holistic approach. Bone fracture normally take 4 to more than 16 weeks to heal, depending on these conditions. For Mrs. F, she does not take any drugs that may interrupt healing process, but she is at increasing age and a passive smoker, which are factors that may influence her recovery, apart from her current poor physiological conditions. Mrs. F is referred to dietitian due to her poor oral intake, which may be a result of Parkinson's disease. Common underlying reasons for PD patient include lack of appetite, chewing and swallowing problem, as well as self-feeding difficulty. The solutions are to treat based on every underlying cause. Patient can have frequent small meals, eat with companion and prepare good surrounding before mealtime to improve appetite. Solutions to chewing and swallowing problem are to educate with safe chewing and swallowing habits, food modification, and exercise to strengthen muscle. Feeding for patients with unstable hands should be assisted by family or caregiver.
Hi, my name is Nuranis binti Mahazi, and moving on to the next discussion. Mr. F is suffering from the Parkinson's disease. Therefore, levodopa is one of the medications prescribed for her to reduce the Parkinson's disease symptoms. Levodopa, or also known as a dopaminergic agent, will stimulate the peripheral dopaminergic receptors and cause GI problems, which are mainly in use as nausea. People with PD also commonly experience low gastric emptying due to aging. Therefore, delayed gastric emptying and high dietary protein intake can also affect the levodopa absorption and increase the feeling of nausea, which lead to a loss of appetite. However, one of the medical nutrition therapy goals for Mr. F is to increase calorie and protein intake. Therefore, we have found that Parkinson's patients are suggested to take levodopa at intervals of 30 minutes before or 1 hour after meals to avoid the food-drug interaction. From the dietary aspect, Firstly, we suggested her to follow small and frequent meals. This is because a study has shown that small frequent meals can help PD patients to overcome nausea. Next, the taste sensation become blunted as we age, that makes us not feeling thirsty. This is what commonly experienced by the PD patients. However, dehydration can lead to confusion, weakness balance problems, respiratory kidney failure, as well as death. Therefore, we prompt Mr. F to consume sufficiently enough water as suggested. Thirdly, we also offer Mr. F micronutrients since PD patients at high risk of getting fracture due to vitamin D deficiency. We offer Mr. F micronutrient supplementations that contains bone strengthening nutrients. British Dietetic Association has been suggested that they should be supplemented with more active form of vitamin D that can help increase the bone density and dramatically lower the risk of the fracture in this patient, especially for those who are immobile.
Next, for the conclusions, the Parkinson's disease dietary interventions demonstrate managing or treating the symptoms of this disease, emphasize more on the protein intake and increase the fluid intake. Besides, adjustments of the dietary intake to relieve the symptoms of this disease, such as small and frequent meals to prevent acid reflux. Lastly, the timing of medications and meals should be monitored, as some nutrients could interfere with the absorption of the drugs. Thank you. That's all from us.